Lakshmi ma'am, good evening.
Someshwar sir, you can start now.
Thank you, Chitrakala. Good evening, doctors. Greetings from the Shield Healthcare. I welcome you for the another knowledge updated web series for episode 18, conceptualized by Dr. Pratibha Singh. I welcome you all for today's web series. And let me introduce our today's conveners, Dr. Priyankur Rai, who is a consultant infertility and gynec endoscopy at Nova IVF Royce Clinic, Siliguri, and is an Indian representative at WTOG and FIGO, National Coordinator and Perinatology Committee, FOXY. He is Zone Coordinator, Infertility Endocrinology Committee, FOXY. And he has published more than 60 articles and authored more than 15 chapters. Yeah, and let me welcome the another convener, Dr. Diksha Goswami Sharma. She is director at Pushpanjali IVF Hospital and Research Center, Agra, and she is an North Zone Coordinator, Perinatology Committee, FOXY, Librarian UP ISR, and awarded first runner-up for UP Shanti Yadav Award in Infertility. And also she has awarded 13 gold medalists on them. And coming to the next convener, our Dr. Vertika Kishore, who is a consultant at Vrindavan Arogya Deep Hospital, Vrindavan, Mathura, UP, and past president Mathura Obs and Gynec Society, executive member of FOXY, ISC 2021 to 22, and executive member of SFM UP chapter, and advisor for Adolescent Health Committee, SMDHM, and she is a recipient of FOXY Wellness of Women Award for Cervical Cancer Prevention in collaboration with Brahma Kumaris. So with this, I hand over the session to Dr. Priyankur Rai to take session further. Yeah. Over to Priyankur Rai.
Thank you. Good evening, everyone. It gives me immense pleasure to welcome all of you to yet another knowledge update series. And today we are doing the episode number 18. This series is a concept that has been brought in by Dr. Pratibha Singh ma'am, brilliantly taken forward, and of course persistently continuing over the last, I would say, 8 to 10 months. The best part about this series is the enthusiasm that has been set in by this series, by the quiz that goes around by many Foxians, which really helps us in taking this sessions forward. So first of all, I would like to welcome Dr. Pratibha Singh ma'am. Can I have the CV, please? Pratibha Singh ma'am, who is the program director of this program. Ma'am is a consultant laparoscopic laparoscopic surgeon and IVF specialist, director at the Healing Touch Multi-Speciality Hospital in Bhagalpur. She is currently the national coordinator for International Academic Exchange Committee of FOXY. She was a past vice president of the Bhagalpur Society and a founder secretary of SOVSI of the Bihar and Jharkhand chapter. It's a pleasure. Ma'am is there with us today, and I would request her to kindly welcome welcome all our faculties and delegates present here today, and also give us a brief about the KU update series.
Thank you, Dr. Priyankur. And good evening, and once again a warm welcome to all of you to this knowledge update series. And I'm happy that today again we have come up with another very interesting, important and novel concept of obstetric practice, with which I'm sure many of us will be benefited. Now, critical care in obstetric through HDU and ICU is relatively a new approach to treat our serious obstetric patients. But before we move on, let me first welcome our guest. And I'm really delighted to welcome our pride of Bihar, Padam Shri Dr. Shanti Roy ma'am. She has recently been honored by Padam Shri, and she has made us all proud. So once again, I congratulate ma'am for getting this prestigious honor. Congratulations, madam. And thank you very much. Yeah, madam, we are really proud of you, ma'am. And I'm really happy by your presence in this knowledge update series today. Once again, a warm welcome to you, ma'am. And at this juncture, I also want to welcome our guest of honor, Dr. Yashodhara Pradeep, madam, past Vice President FOXY, and our special guest, Dr. Komal Chauhan, Chairperson FOXY Medical Disorder in Pregnancy Committee. A warm welcome to both of you, madam. Now, the care of critically ill pregnant patient is a unique challenge as patient deteriorates very fast. And in India, most of the public health and even our private setups also, they do not have this separate care unit for high-risk pregnancy and also for the postpartum mothers who have complications. Although a lot of advancement has been made to promote better health facilities, but still it is not practical to have separate obstetric ICU. But definitely the concept of dedicated obstetric HDU can be advocated in all our obstetric care units, or a hybrid model of obstetric ICU or obstetric HDU can be suggested, especially for the critically ill obstetric patient. And who can be the best person than our past President Foxy, a very versatile personality, down-to-earth person whose dedication towards Foxy as well as towards his profession is known by all of us. And he's also a resource person for preparing guidelines on obstetric HDU and ICU for Government of India. So I most humbly welcome Dr. Alpesh Gandhi, sir. He will be joining a little bit late. And today he will talk. His talk will help us to build the confidence in dealing with such critically ill obstetric patients. So looking forward for his talk today. And I would like to welcome sir. And with this, I also want to welcome our chairperson, Dr. Vidhu Mudgal madam from Ludhiana, and Dr. Lalita Shukla madam from Allahabad to this forum. So welcome, madam. And now our debaters are again young, academically sound, upcoming gynecologists. So I would like to welcome Dr. Archana Singh and Dr. Munjal. Hope we have a fruitful discussion today. So welcome both of you. And to judge them, we have equally accomplished judges, Dr. Lakshmi Shrikhande madam and Dr. Sujata Dalvi ma'am. So I welcome both of you to this forum. And last but not the least, our conveners, whose constant involvement is always needed by me and for this series to run. So welcome Dr. Priyankur Roy, Dr. Diksha Goswami, and Dr. Vartika Kishore. And from here, I hand over the session to you all for further proceedings. So once again, a warm welcome to all of you and thank you so much. Over to Priyankur.
Thank you so much, Pratibha ma'am, for that warm and kind words. So as for people who have already joined our series before, we know that we have a quiz question, a surprise quiz that happens at the end of the session, of the previous session, and the answer is given on the next session. So the question this time was, an embryo should be visible by transvaginal ultrasonography with a mean gestational sac diameter greater than or equal to 18 mm, 20 mm, 23 mm, or 25 mm. The correct answer is 25 mm. So this was the explanation as per the ACOG practice bulletin on ultrasound in pregnancy. So I would now like to announce the winners of the quiz. So the first prize for this quiz, who wins a certificate and a book on the Mediscan Manual of Fetal Echocardiography by Dr. Suresh Sheshadri, is Dr. Pungudai Selvaraj. So congratulations, Dr. Pungudai. We have other fastest finger first winners as well. So they are Dr. Shefali Pandey from Kanpur, Dr. Nibha Mohan from Patna, Dr. Ramadevi Kolli from Vijayawada, Dr. Pankuri Goyal from Jaipur, and Dr. Fatima Shiba from Lucknow. Congratulations to all of you. As we go ahead with the further quiz sessions, you all will realize that this quiz is not only attended by juniors, but seniors as well, and across the whole length and breadth of the country. So now it gives me immense pleasure to welcome our chief guest to this program. So I would like to welcome none other than Padma Shri Dr. Shanti Roy ma'am. We are so happy and honored that you have joined us today. She has been recently awarded by the Padma Shri Award by the Honorable President of India. She has been the professor and head Department of OBGYN at the Patna Medical College. She is a pioneer in reproductive medicine in the eastern region, in the country, and also worldwide. She is currently the chairperson of the ISAR Patna chapter. She has been awarded by a number of other awards, including the Icon of Health Award, Icon of Bihar Award, and the Dr. Pride Award. It's a matter of pleasure. Ma'am is there with us today. I would request ma'am to kindly say a few words to everyone present here today.
Thank you very much, Dr. Priyankur, for your very nice words. Thank you so much. Dr. Pratibha, Dr. Priyankur, Dr. Lakshmi Shrikhande, Dr. Professor Yashodhara, and everybody else present in this webinar. It is really my pleasure to be here as a chief guest. And I am very happy. I congratulate Pratibha because you are doing so much. I am really proud of you.
Thank you,
It
madam.
gives us immense pride that you are working and you are doing so much. It will definitely go and create a name of Bihar in not only in India, but also outside. It is
Thank you.
very good. It is my pleasure to be the chief guest here. And you know, this critical care in obstetrics, it is a very important, as you told already, it is a very important chapter. And actually it is near to my heart, not only to my heart, but I think all over the globe, all over the world. And that's why so many research, so many data collections, so many conferences, so many seminars are constantly being done on this maternal care and critical care. And daily we get newer guidelines, newer suggestions, newer protocols. Every hospital has got a new protocol so that the maternal life can be saved. And it is very nice that you are trying to give knowledge about this critical care so that we can save more mothers, and all those who are attending this conference, they will definitely be benefited by this webinar. So thank you very much for inviting me. Thanks a lot to all of you. Thank you very much.
Thank you, madam. Thank you so much.
Thank you, Shanti ma'am, for being present with us today. It definitely does mean a lot to us, ma'am. Thank you so much. So now it gives me pleasure in welcoming our guest of honor for today's evening. I would like to welcome none other than Dr. Yashodhara Pradeep ma'am. She is an ex-professor and head, Department of OBGYN at the DR RM Lohia Institute of Medical Sciences in Lucknow. She is currently the president of the Lucknow OBGYN Society, vice president-elect of FOXI, past vice president of IMS. In this last year or so, we have seen her commitment to the extreme. She, whenever she is traveling abroad as well, if she commits to something, she definitely made it a point to attend it irrespective of the time. So it's a matter of pleasure, ma'am. You have joined us today, requesting you for a few words of blessings to all present.
Madam, you have to unmute yourself, madam. Please unmute yourself.
Thank you, Priyankur. You are more dedicated person than me. I have seen you since I have seen you and seeing all the webinars in which you're progressing so well that from one to other, everybody is taking you as a coordinator. Probably I am also going to take you as a coordinator for when I am going to be vice president. Thank you so much for your kind words. So good evening, everyone. It is really my proud privilege to be part of KU series update, KU series 4, episode 18. My heartiest congratulations to Dr. Pratibha,
Thank you.
who is working in a small place of a Bhagaipur and making a dent into the into the FOXI. So it is really something, because our all members, whether they are working in a small place or in a big place, they all working hard. So Pratibha, my congratulations to you, and I wish for success in all your endeavors. You are going to be probably you are aspiring for a chairperson of some committee this year. I'm sure that you are going to get it. This KU series on a very important topic. This is a critical year in obstetrics. As already has been said, that it has been very much closely related to maternal mortality. We have seen the places where the CCU and ICUs are available, the maternal mortality is less than comparison to the places where the CCU and ICUs are not present, facilities are not present. We all know that we appreciate the intervention of Government of India, their efforts and actions, who have taken into it and made it a point that critical care beds have to be available in all private or the government setup, just to save the life, especially the pregnant women. Most of the southern states have already achieved the SDGs, which is 70 per 100,000 births, live births, except few in the southern area. But if you see the India, there is still 24 states and 450 districts still have to achieve the SDGs. MDGs were supposed to finish by 2015, we could not reach. So the SDGs has come, and we are supposed to reach to the 2-digit maternal mortality by 2030. But we are doing it good. So I'm very happy, and I'm sure that by that time, the India will be able to achieve this goal. And I really want from my heart that India should achieve. India is progressing so well in all the scenarios, and health scenario also, it is doing very well. So thank you so much for making me a part of this program, Pratibha. Thank you very much. And my regards to Dr. Shanti Rai, and my friend Lakshmi Srikhande is there, and Dr. Alpesh is not joined probably. So my regards to Dr. Alpesh Gandhi. Thank you so much. And the Shield Healthcare.
Thank you, Yashodhara ma'am. Thank you so much for joining us. Your words mean a lot to us. Thank you so much, ma'am. So now it gives me pleasure in welcoming our special guest for today's evening. And before I do that, I would kindly like to request Dr. Shanti Roy ma'am and Dr. Yashodhara Pradeep ma'am to kindly stay on, because it will be nice if you could felicitate the winners of the quiz that should be just right next after this. So now it gives me pleasure in welcoming Dr. Komal Chauhan ma'am. She is Medical Director of the Chauhan Maternity and Nursing Home. Ma'am is currently the chairperson of the Foxy Medical Disorders and Pregnancy Committee, member of Managing Committee of MOGS. We have gone through a CV a number of times, but today I would like to, on behalf of her, probably would like to make an appeal. She is Foxy rather is trying to make a world record, Guinness World Record of having uploaded the pledge on Facebook for the maximum number of pledges uploaded between 10 to 11 o'clock tomorrow. So the pledge is on most of the WhatsApp groups. So kindly record a short video with the pledge and upload it by 10 to 11 tomorrow in the morning. So that would be a great thing. And Dr. Komal ma'am is definitely striving a lot towards it. Every other day she's doing a webinar, and she has done a lot towards this Medical Disorders Committee. Ma'am, it's a pleasure you have joined us in spite of your busy schedule. Requesting you to kindly say a few words.
Thank you so much, Priyankur, for the kind introduction. And at the outset, I would really like to congratulate Dr. Pratibha Singh for successfully conducting, 18 episodes of Knowledge Update series. And this work of knowledge dissemination among members is really, really very important. And today the topic chosen, critical care in obstetrics, is so close, because as a chair of medical disorders in pregnancy, we come across so many women with complex medical disorders. Women are getting pregnant, like with heart disease. The pregnancy rate is increasing with hepatic and with transplant and all that. And when even anemia, what we're talking about, the awareness which I'm coming, a severe anemic patient lands up in an ICU. So critical care is a part and parcel of every tertiary care. It should be a tertiary care institute, and wherein every patient should have access to critical care in every nook and corner of India. So this is a very interesting webinar, and I really, really thankful for calling me as a special guest. Along with, I give deep regards to our chief guest, that is Shanti Roy, and Dr. Yashodhara Pradeep, guest of honor. Really, really, it's so nice to meet them and be on the stage with them. And she has chosen a very able person, Dr. Alpesh Gandhi. He is the master of critical care. He has done series of these webinars all over, and I think he is the most he has propagated this necessity of critical care to everybody. So I'm really waiting to hear from Dr. Alpesh Gandhi, sir. And I think the quiz section and the prizes is something which is a USP of this webinar, which stands out. And that is the reason a lot of people are interactive. It makes the audience also interactive. So I'm waiting to hear from the debaters. I can see Munjal here, whom I know very well. He's working in the committee. Dr. Sujata Darvi, Dr. Lakshmi Srikhande. So I'm really happy to see so many people logged in. Priyankur is doing a fabulous job. So thank you so much. And as Priyankur has already said, I would like to just tell that Foxy is coming up with an awareness pledge. We want a maximum number of people saying the same sentences and uploading the videos on Facebook between 10 to 11. The link is there on all social media. It is on the official Foxy social media handles like Twitter, Instagram, and Facebook. So I request everybody to follow those handles, and the link of the page is there, and they just have to record a video saying a very simple. It hardly takes like 8 minutes. So the sentence is, today, on occasion of Iron Deficiency Day, I pledge to help India break free from anemia. And that is our mission. So I just want you to record this sentence and post a video. And I want you to propagate this message so that more and more people join. We have to show the power of Foxy. That Foxy is such a large organization of gynecologists. And how can we reach to every community and how we can propagate this pledge? So let's see, tomorrow is our task day. So do stay tuned and please join Foxy. And today is a very important day. Actually, there is a Shanta Kumari Madam's Violence Against Women webinar happening, and I am wearing that orange to support Dira. And the inauguration of the program is just with this program. So really, I think these two crucial issues today, that's violence against women and anemia, both need to be handled. And I wish all the best to all the people who are organizing this webinar. And for this webinar should go down, the knowledge dissemination should go down, more number of series. We are looking forward for future programs. Thank you so much.
Thank you, Komal ma'am, for the wonderful words. I'd like to congratulate you and wish you all the best for tomorrow, and also congratulate Team Foxy, Shanta ma'am, Madhuri ma'am, yourself. We can all see you wearing the Dhira t-shirt, and of course, violence against women, as you said, is another very important issue that needs to be addressed as well. So thank you so much, ma'am, for joining us in spite of being on the other session as well.
Even I'm wearing orange today because of
Yes. Yes, I think that is the need. So very good.
Yes.
Sure. So now we will move on to the quiz, Know the Legend. So this time we had, can I have the next slide, please? I'd just like to make an honest confession when I see this slide. This is the 18th episode that I'm conducting this quiz, and I hardly knew 2 or 3 people out of the total Know Your Legend photos that were put up. But every time I see the number of participants who answer the quiz is enormous. I mean, this time we had 118 number of participants who answered the quiz, and out of that, 104 participants answered it correctly. I mean, that's awesome. I mean, isn't it? So this gentleman, Dr. Bjorn Ibsen, he's a Danish anesthetist and founder of the intensive care medicine. So he was the Know Our Legend quiz this time, and I would like to congratulate the winners. So I'd like to first of all congratulate the Dr. Shaili Agarwal from Kanpur, who has answered this quiz correctly. She gets a book on Practical Guide for Obstetricians by none other than Dr. Shanti Roy and Dr. Shipra Roy. So congratulations, Dr. Shaili Agarwal. The second prize winner in this category is Dr. Payal Bhargava.
You are muted.
So sorry for that. I'm sorry for that. She also wins a book on the Holland and Bruce Manual of Obstetrics, the 4th edition. Congratulations, Dr. Payal. The third prize winner is Dr. Lata Gupta from Sitamarhi, and she also wins a book on the Iron Donors Practical Obstetric Problems. So can I please invite Dr. Shanti Roy ma'am to kindly felicitate these winners?
What I have to do? How? Where is she?
Ma'am, you can verbally felicitate them.
Okay. Congratulations a lot. Actually, really, I also could not recognize who was that legend. It was a difficult question, and you won the prize. Congratulations. We all are very happy that you won the prize.
Thank you, madam.
Thank you, Shanti ma'am. Thank you so much. So now we move on to the consistent prize winners. So the consistent prize winners are the winners who consistently answer it correctly in most of our sessions. So this time, the consistent prize winner award goes to Dr. Srivastava from New Delhi, who gets a book of the Holland and Bruce Manual of Obstetrics 4th edition. So congratulations, Dr. Srivastava. The other winners on this category are Dr. Shirali Runwal. Now, every session, I keep mentioning this, and I don't get tired of mentioning this because she is a 3rd-year postgraduate student. Be it the senior category, be it the junior category, be it the postgraduate category, she is there as a prize winner in most of the sessions. She has won prize in the KU series like consistently, I think, for the 17th or the 18th time. And even yesterday, there was this Medha quiz program, which happens for the Foxy postgraduates. And she was the winner in that as well. So congratulations, Shirali, you're making it a habit to win, and I'm sure you're going to be Prof. Foxy is going to be proud of you in the future as well. So
Very
congratulations. Our next winner in this category is Dr. Pratima Verma from Kanpur. Congratulations, ma'am. Then we have Dr. Kaushik Datta Pramanik from Kolkata. Congratulations, sir. Dr. Anita Rajoria, ma'am, from New Delhi. Congratulations, ma'am. She does attend our quiz programs regularly and she keeps winning. So congratulations, ma'am, once again. Then we have with us Dr. Pramila Malik from Gurgaon. Congratulations, ma'am. Can I invite Dr. Yashodhara Pradeep, ma'am, to kindly felicitate them?
Thank you, Priyankur. It was my privilege that I've been asked to felicitate them. So heartiest congratulations to all the winners, in which there's one is my student is a Pratima from Kanpur. So I really feel happy that Pratima is there, and my heartiest congratulations, Pratima, if you are there, to you and Dr. Kaushik and Dr. Pramila Malik from Gurgaon. And one more, I just lost this thing, is who was that?
Dr. Anita Rajoria.
Dr. Anita Rajoria. Dr. Anita Rajoria. Yes.
Dr. Shirali.
Dr. Shirali.
And Dr. Srivastava from New Delhi.
Yeah. So congratulations to everyone.
Thank you so much, ma'am. I am sure it means a lot to them. So now we have the fastest finger first awards. So to present them with the certificates for winning this in this category. So it will be Dr. Mamta from Varanasi. Congratulations, Dr. Mamta. Next, we have Dr. Meena Samant from Patna. Again, ma'am is a regular in the quiz program and she keeps winning. So congratulations, ma'am, and she keeps the enthusiasm of us on as well. Dr. Bean Singh from Patiala. Congratulations. Dr. Rajasi Sengupta from Nagpur. Dr. Anita Bansal from Hathras. Dr. Savita Tyagi from Agra. Dr. Vinita Avasti from Kanpur, Dr. Apurva Bhattacharya from Guwahati, Dr. Sulekha Kumari from Rohtak, Dr. Supriya Jaiswal from Patna, Dr. Bandita Sinha from Navi Mumbai, Dr. Atima Bharti from Ranchi, Dr. Sneha Bhuyer from Yavatmal, Dr. Chitra Bansal from Dholpur, and Dr. Sheila Jamal from Bareilly. So as I was saying in the beginning, a mix of seniors, juniors from across the length of breadth of the country. So congratulations to all the winners. And I would now like to invite Dr. Komal Chauhan, ma'am, to kindly felicitate them.
I think
she's not there.
She's not there.
Okay. Can I invite Yashodhara, ma'am, to kindly felicitate them, ma'am?
Thank you, Priyankur, once again. And my heartiest congratulations to all the winners of Fastest Finger First. It is not a joke, because Fastest Finger First is because we are also having the IMS quiz. And you see there's so many people who are right, but only those get the reward of it who are Fastest Finger First. So really I admire you for your knowledge, and Pratibha has rightly kept the name of this series as a knowledge update. So by quiz, you are really making this, by quiz and by doing the important topics, Pratibha, is a very good idea, and you have really chosen a very good heading and topic and title, everything. So again, my congratulations to all the winners.
Thank you.
Thank you so much, ma'am. Thank you so much. So now, as per the protocol, we usually have the winner of the Know Your Legend quiz who presents a little bit about the legend. So this time the winner was Dr. Shaili Agarwal, who is the Associate Professor, Joint Secretary of the Kanpur OBGYN Society. Unfortunately, ma'am could not join us because of some connectivity issue. We have with us Dr. Diksha Goswami, who is she has been awarded the first runner-up for the Shanti Yadav Award in Infertility, winner of the Best Paper, First Women's International Health Summit, and a co-convener for me with this program and a good friend of mine to kindly present about Dr. Bjorn Ibsen. So Diksha, over to you.
Yeah.
Diksha is also our student.
Yes. So nice to see you here, ma'am, and meet you, even though virtually today.
So it's so nice me to see you. I'm feeling so proud of it.
Yes, ma'am. Same here, ma'am. So at the outset, a very warm good evening to all my seniors, mentors, special chief guests, and we all feel so honored that an obstetrician has got a Padam Shri this time, Dr. Shanti Rao, ma'am, my teacher and guest of honor, Yashodhara Pradeep ma'am, special guest Komal Chavan ma'am, learned speaker and our past president Alpesh Gandhi sir, all the chairpersons and senior faculty today. During these last 18 episodes, we have had the opportunity to know about various legends in the field of obs and gynae. And today I get the opportunity to talk about another legend, Professor Bjorn Eg Ibsen, who is credited with saving millions of lives. Dr. Bjorn A. Gibson was a Danish anesthetist. He is a founder of intensive care medicine. He graduated in 1940 from medical school at the University of Copenhagen and trained in anesthesiology at the Massachusetts General Hospital, Boston. He became involved in 1952 poliomyelitis outbreak in Denmark, where more than 2,700 patients developed the illness in a 6-month period, with 316 suffering respiratory or airway paralysis. Treatment had involved the use of few negative pressure ventilators available, but these devices, while helpful, were limited and did not protect against the aspiration of secretions. After detecting high levels of CO2 in the blood samples and inside a little boy's lung, Professor Ibsen changed the management directly. He instituted protracted positive pressure ventilation by means of intubation into the trachea and enlisted 200 medical students to manually pump oxygen and air into the patient's lungs. He was involved directly in reducing the mortality from 90% to around 25%. Patients were managed in dedicated 3 special 35-bed areas, which aided in the charting and other management. So this is a prototype of the head ventilator, which was used in Copenhagen during this polio epidemic in 1952, which Professor Ibsen helped to devise. In 1953, after the outbreak had subsided, he was offered a job at the Copenhagen's Commune Hospital, where he was asked to supervise surgical patients in the recovery room and the wards. Later that year, he turned the surgical recovery ward into a unit where all types of patients could receive critical care. He took a surgical recovery room, got sole charge of it, and turned into what he called an intensive therapy unit. He had his first patient there in 1953. This was the world's first dedicated intensive care unit, an achievement in itself, and all the more so because Ibsen was an anesthetist. It was very difficult for him to get charge of a unit where patients were for the first time under the control of an anesthetist. So this is a picture of the first intensive care unit. Although others had raised the idea of treating all critical patients in the same place, Ibsen was the first to make it a reality. He was in the forefront, and for this he won the Danish poliomyelitis and anesthetic medals and the J.E. Perkins medals. And 26 August is celebrated as a Bjorn Ibsen Day, the day when he proposed positive pressure ventilation to save lives. And we all owe so much to this exceptional doctor. Thank you.
Thank you, Diksha, for that wonderful presentation and enlightening us about this wonderful gentleman. So thank you so much for that. So now it's time for us to move on to the most awaited talk of the evening on role and scope of obstetric HDU and ICU in critical care in obstetrics. So I would like to first of all welcome the guests, the chairpersons for this session. So I would like to welcome Dr. Vidhu Motial ma'am, who is a president of the Ludhiana OBGYN Society. She is a member of the Innerville Club as well as the Food and Drug Committee and the Perinatology Committee of FOXI. She is also the organizing chairperson of the Northern Yuva FOXI that's going to be held at Ludhiana. It's a pleasure, ma'am, that you have joined us. So welcome. And with us, we also have Dr. Lalita Shukla ma'am, who is a consultant OBGYN at the Arogya Niketan in Prayagraj. She's the president of the Allahabad OBGYN Society and her special interest is high-risk pregnancy. So can I invite now Dr. Lalita Shukla ma'am to kindly invite our speaker, Dr. Alpesh Gandhi sir, for this talk.
Good evening. Good evening to everyone. At the outset, I must congratulations respected Shanti Roy ma'am for the achievement. I would like to thank Dr. Pratibha Singh for the opportunity for chairing this prestigious session. Now, today's topic is of interest to all of us, as most of us are dealing with obstetrics on a day-to-day basis. We all know the basics regarding management, but at times we are faced with a situation in which decision-making and implementation is very difficult. I'm sure the CME is going to help all of us in such situations. Now, I have been given the task of introducing Dr. Alpesh Gandhi, the immediate past president, who actually needs no introduction. Versatile and active as he is also a perfect guest speaker for the topic, being a high-risk pregnancy expert, critical care in obstetrics expert, hospital management expert. He has been the President Folksy 2020, Vice President Folksy 2013, Governing Council member of ICOG Folksy 2016-17, Chairperson Practical Obstetrics Committee, past President Ahmedabad Obstetric Gynec Society, and past Secretary also. He is a National Coordinator, Emergency Obstetric Care, Program of GOI and Folksy, member PC PNDT Act Implementation and Supervisory Body, Ahmedabad District. He is a resource person for preparing guidelines of establishment of obstetric HGU and ICU for Government of India. His book on principles of critical care in obstetrics is available in more than 5,000 world-renowned medical libraries, published by an international publisher and translated in Chinese and Spanish language also. He is instrumental for establishment of many obstetric HUD, IUC, ICU across India. He has received Best Society, Best RCH Activities, and Best Publication Award. He is a practicing gynecologist for 27 years. So Dr. Alpesh Gandhi, welcome, sir. Welcome, and please give your talk.
Thank you very much, Chairperson, Dr. Ladika ji, Dr. Vidhu ji, for the kind words and generous introduction. Thank you very much for giving me this, Dr. Pratibha ji. Thank you very much for giving me this opportunity to share my views on this very interesting topic. I would like to congratulate you for this excellent work you are doing, spreading good academics across India. I am going to speak on a topic, scope and role of obstetric HDU and ICU. I would like to dedicate this talk to my patients because of whom I could generate interest in critical care in obstetrics. I would like to divide this talk in 2-3 topics: genesis, concept, its impact means will in
Sarah has been logged out.
Yes, ma'am.
Yeah. We'll wait for them.
Till Alpesh sir joins back, can I request our respected chairpersons Lalita ma'am or Dr. Vidhu Mudgil ma'am to kindly say a few words for our regarding the obstetric ICU and critical care management.
Dr. Lalita. You have to unmute yourself.
Can you hear me?
Yes, yes.
Most of us have our nursing homes and hospitals. But the need for a post-op room with special critical care is very important, because at times, I think at least in North India, most of the hospitals don't have a critical care unit for obstetrics only. It is a general critical care, ICU or ICCU. And the patient usually lands up in the ward with some problem, and then there's a rush to take her back to the ICU or ICCU and manage her. So I think it is very, very important to have a proper obstetric ICU, so that, and the trainee doctors, they should be taught the basics of management in such cases. And I think in future, all the hospitals, private or general as such, they should be asked to have such a place where the patient can be put for the first 24 hours of operation or delivery or whatever. I think Dr. Alpesh is back.
Yes, yes.
So we can hear him again now.
Sorry for the technical problem. Some net problem was there. So in the year of 1997 and 98, maternal mortality rate of India was 398, and India was required to reduce maternal mortality to 109 by 2015 as per the MDG goal. Several schemes were introduced in India to improve the maternal mortality rate. But the Janni Suraksha Yojana has brought the revolution in Indian obstetrics. And because of this scheme, which was introduced in the year of 2005, has increased to 84% in 2015. In 10 years, drastically improvement. There was drastically improvement in the hospital delivery rate. And because of this, maternal mortality rate was also increasing every year by 15 to 10, and at the pace of improvement in maternal mortality rate, we were expecting that we would easily achieve the MDG goal by 2015. The maternal mortality rate reached to 178 by 2011, and surprisingly by 2015 it has reached 162. So the maternal mortality rate, which was improved every year by 15 to 20, after 2011, in next 4 to 5 years, it has improved only by 14. Why this observation? Why the progress of improvement in maternal mortality rate stopped in India? More and more women are reaching to the hospital. Our doctors are dedicated, they are experienced, they are available at the hospital. And now pregnant women are dying at the hospital. Now two types of women were dying, one at home and another who are reaching at the hospital and dying. As per unpublished survey in India, maternal mortality rate in hospital delivery is somewhere between 50 to 70 in 2015, which was 3 to 4 times higher than the maternal mortality rate in developed world, which is less than between 10 to 20. So why this much big gap in maternal mortality rate in hospital delivery in India? This is because of lack of quality obstetric healthcare in our institutions and hospitals. India is one of the countries having highest incidence of PPH, eclampsia, prematurity, IUGR, diabetes, septicemia, and many other pregnancy-related complications across world. If we look at the incidence of placenta accreta, then compared to developed world, the incidence is higher in developed world compared to us. But sad part is case fatality rate of all these complications is significantly high in India. Case fatality rate of placenta accreta is nearly 8 to 10% in India. So why this much high case fatality rate in India in our hospitals? This is because of the lack of quality obstetric healthcare. Maternal mortality is just the tip of an iceberg, and there is a vast unseen base, which is known as the near miss cases. And as per the WHO 2013, they declare that the near miss case incidence can be as high as 8.23% in India. Interesting article was published in Lancet May 2013, and in which in this study, the institutes were divided into two groups, one in low resource countries and another in high resource countries. And in both the groups, same type of prophylactic, preventive and prophylactic treatment were given for the postpartum hemorrhage by Eutotonics and Oxytocics. And as the institutes were same type of institutes, same type of treatment were given, it was expected the same type of results. But surprisingly, the maternal mortality rate was high in countries of low resource countries. So this was, again, several explanations were given, but most likely explanation given was lack of appropriate level of care, lack of teamwork, and absence of critical care in obstetrics in low resource countries like us. And this is again because of the lack of quality obstetric health care. So what is quality obstetric healthcare? Quality obstetric healthcare means use of sophisticated state-of-the-art equipment and technology, facility of invasive monitoring, facility of immediate life-saving interventions, facility of skill-based services provided by skilled and experienced persons, and facility of 24 hours facility of monitoring and close monitoring, frequent monitoring, and all this can be accomplished only in specialized dedicated obstetric ICU setup. But in small towns, in small setups, everywhere ICU setup may not be possible. So, so the concept of need of obstetric HDU came. HDU means high dependency care unit, where we can take care, we can admit and take care of high risk pregnancy, which are likely to may turn up into critical care or may turn critically ill also. So there is agreement in the developed world on the need of the intensive care facilities for obstetric patients, maybe ICU or HDU. So what is obstetric ICU then? It is an ICU which is dedicated to manage only obstetric managed by staff oriented for obstetric physiology and pathology. Like MICU, where only medical patients at present before the invent of obstetric ICU, our patients had to admit in MICU or SICU, which are not developed or established for obstetric patients. They were started for the medical reasons or for the surgical reasons, whereas dedicated obstetric ICU means only for obstetric patients having critical obstetrical or medical or surgical complications. What is obstetric HDU then? HDU is an area in the hospital where high-risk patients can be cared.
Sir, you have to unmute yourself, sir. Yes.
So when patient admitted in HDU becomes critically ill, can be shifted to ICU, or when patient admitted in ICU becomes normal or improved, can be shifted to HDU. And that is why it is known as the intermediate care units. And it is also known as
Sir, you have to share your screen again, sir. We are not able to see your screen, sir. Yes.
So, and then after the lot of advocacy from Foxy, Government of India also agreed for the need of obstetric HDU ICU in the country for the further improvement in maternal mortality and morbidity. And Government of India came out with the guidelines, which was published in the March 2016. And fortunately, I was the main resource person for preparing both the guidelines, obstetric HDU ICU guidelines and operational guidelines, which was released then in the month of December 2017. So it was to say that the first revolution was happened in Indian obstetric when Janani Suraksha Yojana was introduced, but this obstetric HDU ICU concept and established has again brought another revolution in Indian obstetrics. Government of India has also revised its health system model for the maternal health in India. We all know that previously it was a 3-tier system, still skilled birth attendant, then basic emergency, and then the comprehensive emergency care. So it was a pyramid of 3-tier, and then which is now a 2-tier more tier were introduced into it, HDU and ICU, and now 3-tier system of maternal health services in India has converted into 5-tier services, and this is the newly declared maternal health system model in India by Government of India. So there was coming to the concept or the scope, it was told that when we already have MICU, SICU, why a specialized HDU or ICU for obstetric patients are required? Then the main thing is in MICU and SICU, anesthetists and obstetricians are not available who are acquainted with the obstetrical conditions and complications and pathology and physiology. So here we have presence of anesthetists, obstetricians 24/7 in HDU ICU. There is assured services of specialty.
Net is coming and going.
Medical officer is trained in obstetric emergencies. Average nurse patient ratio is 1:2 in HDU, and average nurse patient ratio is 1:1 in ICU. As per the different studies, minimum 5 to 7% of total number of delivery may require admission in HDU, and average stay when patient is in HDU is 2 to 3 days. And considering this, minimum 3 to 4 beds are suggested in HDU when delivery caseload is 500 or more.
Excuse me,
And
sir.
6
Sir,
to 8 beds.
you have to share again, sir. Your screen is not visible, sir.
There is some internet problem continuously going on anyway.
Yes, sir.
So it is suggested need for 3 to 4 beds in obstetric HDU when case load of delivery is 500 and it should be located near to the labor room or operation theater, obstetric operation theater, and whenever is required, patient can be shifted easily and promptly to the labor room or obstetric theater. This facility should be there. Isolation room should be there. Privacy and we should ensure privacy. And important thing is there should support system should be available, like facilities should be there, like nearby NICU facility, in-house or nearby NICU facility is very, very important. Fully equipped laboratory working for 24 hours on all 7 days is very important, and blood bank facility with the facility of blood components should be available in-house or in nearby obstetric HDU and ICU. And lactation support, breastfeeding is allowed in obstetric HDU. Babies are usually not allowed in obstetric ICU, but breast pump facilities should be made available. So these are the facilities in HDU ICU. Important thing is when patient is in HDU ICU, infusion pump and syringe pump is very, very important to deliver the drug in a proper dose and at a proper time, particularly when patient is on some sedatives or anesthetic drug like propofol, or some on vasopressor drugs like dopamine, dobutamine, or when she is on nitroglycerin, nitroprusside, or on anticoagulant like heparin, thrombolytic or insulin drip is there. So for delivering of drug in a proper dose at proper time, infusion syringe pump is very, very essential when patient is in HDU ICU. Wall-mounted suction intubation set is very important. Again, when patient in HDU ICU require close monitoring, frequent monitoring, and so the monitoring apparatus like BP apparatus, glucometer, cardiac monitor with CP monitor, pulse oximeter, multipara monitor, all these facilities should be there in the establishment of obstetric HDU, so the patient can be monitored better again crash cards or baby resuscitation card fully loaded with all the required basic life support medication should be there, so that anytime if patient require any such medicine can be taken care. Central oxygen supply, cautery machine, generator, inverter, stock of emergency drug, O negative blood facility, all are very, very important and essential aspects of its establishment. Again, we have to deal with two patients, mother as well as fetus, and fetal surveillance is very, very important, which is not possible when our patients are admitted in MICU or SICU. So for the fetal surveillance, ultrasound machine with the facility of color Doppler and fetal echo is also a very important aspect, and a CTG machine is also very, very important for the fetal surveillance when patient is in HDU ICU. Again, a life-saving technology machine is very, very important part. So the BiPAP or defibrillator, AED machines and ventilators are important part. And when patient requires such life-saving technology or support, we can provide them when patient is in HDU ICU, and we can save these such type of patients. AED machines, AED is now available even at all the public places like in a railway station or airport. We can see AED boards. So AED is very, very, these all are very essential life-saving technology, and we should know the basic of all this technology, how it is used and how it is worked. And one important thing, our ICU should have the facility to be converted into obstetric OT within 1 or 2 minutes if it is required. Like sometimes we may need to perform resuscitative or which is cesarean section, which is previously known as the perimortem cesarean section. So any such type of sometime we may require such type of treatment care. So it is always better if we have the facility where we can convert this HDU, this obstetric ICU in OT. If we look at the scope, then the accidental hemorrhage, placental abruption, ovula uterus, placenta previa, PPH, HELP syndrome, DIC, hemolysis, all can lead to hemodynamic instability. These type of patients may require close monitoring. There is a massive hemorrhage, may require massive blood transmission, and all these patients cannot be managed in routine floor, cannot be closely monitored, and such services cannot be possible, massive blood transmission and all this. So better if they are admitted in obstetric HDU ICU can be taken care better. Similarly, when patient is having severe preeclampsia, we may require frequent blood pressure monitoring, we may require urine output monitoring, and sometimes patient is on eclampsia, we may require to see the reflexes. We need to see whether patient is not having mexal toxicity. So all this cannot be possible in routine floor because there is a heavy workload and monitoring is not possible. 1-to-1, 1:2, or 1:1 nurse, 1:1 nursing facility is not there. So they require admission where such type of facility is there in obstetric HDU ICU and can be taken care better. Again, patient with either in placenta accreta, retained placenta, all may require, can lead to massive or torrential bleeding, may require blood transmission, massive blood transmission, may require obstetric hysterectomy. So many things, such type of patient may require post-operative care is very, very essential. Monitoring is very important. So better if these patients are admitted in obstetric HDU ICU. Again, rupture ectopic, obstetric hysterectomy, rupture of the uterus, or when there is a perforation while performing abortion. All this can lead to bleeding, can lead to some laparotomy, can lead to surgery, can lead to blood transmission, and post-operative care is important. So these all are the patients should admitted into HDU. Again, when patient is having sepsis, obstetric patient having sepsis or burns, can lead to hypovolemic shock, can patient. So better if we can admit such patients in obstetric HDU and we can take care of such patients. Again, when patient is having some medical disorders like jaundice or diabetes or acute renal failure, asthma, some cardiac problem, all these patients may require specialist, may require teamwork, multidisciplinary teamwork. Close monitoring is required, frequent investigations are required, so many things are required in such type of patients. So better if we can admit such patients in HDU ICU, they can be taken care and we can save such type of patients. So these are all, this is the scope of obstetric HDU ICU. So when to admit patient in HDU, when patient is having hemodynamic instability, or when patient is having respiratory dysfunction or neurologic complications, or having acute kidney injury, hematological complications, or when patient require single organ support, can be admitted in obstetric, should be admitted in obstetric HDU. But when patient develop requiring 2 or more organ system support, when invasive monitoring is required, or ventilatory support is required, or when inotropic support is required, massive transfusion, blood transfusion required. Sometimes patient may require renal replacement therapy, and when we are thinking that this patient is having the risk of sudden catastrophic deterioration, multidisciplinary team is required. All such patients should be directly admitted into ICU, obstetric ICU. So these are the parameters from which we can know when which patient should be admitted in routine floor, in HDU or in ICU. So when systolic blood pressure less than 90, more than 160, diastolic less than 50, more than 110, when heart rate less than 60 or more than 110, when respiratory rate more than 25 per minute, or urine output less than 30 ml, should be admitted in HDU, should not be admitted at all in normal routine ward or floor. But when such type of patients develop such type of vital data like respiratory rate more than 35, pulse outside the range of 50 to 140, when serum sodium is outside the range of 110 to 160, when pH is outside the range of 7.1 to 7.7, when oxygen is less than 90% on supplemental oxygen. So all these situations cannot be even managed in HDU. And these are the patients directly require admission in ICU or should be shifted to the ICU. So today, more and more often pregnancies are possible after treatment of gynecological, surgical, and fertility problems. And because of these recent changes in the obstetric practice, more and more obstetric patients now require admission in obstetric HDU. And that is why the scope of obstetric HDU increasing day by day. Why the scope increasing? Because now we all know that there is an increase in the incidence of cesarean section, and because of this, there is increase in the abnormal placentation, low-lying placenta, placenta previa, and when there is a combination of placenta previa with previous cesarean section, dramatically there is increase in the risk of placenta accreta. And again, when number of cesarean section increases, the chances of having placenta accreta increase to 2.1%. To 6.7%. So, which incidence of placenta accreta, which was 1 in 30,000 in 60, has increased to 1 in 500 nowadays, and it is the second rank indication for obstetric hysterectomy. Similarly, now ART pregnancy also, there is an increase in ART pregnancy, which can lead to critical obstetric ovarian hyperstimulation syndrome. Now elderly patients these are the elderly patients, many of them are elderly patients. It can lead to either, it can be incidence of multiple pregnancy also increases with this. Because of this incidence of cesarean also increases in ART pregnancy, all this can lead to need for obstetric HDU. Again, incidence of hypertensive disorder in pregnancy increases. Again, across the world, incidence of preterm delivery increases, particularly when there is a previous when there is a when there is no history of previous preterm delivery, then the risk is 7.2, which has increased to when there is a single preterm birth delivery, the risk of having preterm delivery is increased to 17.2, and when there is a previous 2 previous to preterm birth delivery, then the risk increased to 28.4%. Now again, injection tranexamic acid has significant role. There is now massive transfusion protocol. We all are following this. Previously, the concept of management of obstetric shock was different. Now we all know the importance of fluid responsiveness. It is patients are managed as per the fluid responsiveness. Older concept is whether patient is having hypovolemic shock or the euvolemic shock or the hypervolemic shock. But now, as per the newer concept, whether the patient is fluid responsive or not, patients are managed like that. Similarly, there is a redefinition of the sepsis. Such criteria have been removed, and now we are using SOFA score and quick SOFA score. Lots of different now in recent obstetric practice. MTP now allowed even for more than 24 weeks, and highest gestational age where MTP was performed in India was 32 weeks in a case of rape in a girl of 12 years. So such patients and such girls are also require intensive care. Again, elderly primary more than 35 years becomes common in career-oriented couples. Diabetes mellitus incidence is 3 to 7%, and India is the capital of diabetes mellitus. Hypothyroidism is something like an epidemic in India. Incidence of H1N1 is also increasing. Incidence of medical disorder in pregnancy increases. Now, we are also allowing pregnancy after balloon mitral valvotomy. We are also allowing pregnancy in transplanted patients. Prophylactic dialysis is performed frequently. Now, recently, we are also facing problem of pregnancy with COVID-19 infections. So lots of new situations are there, lots of new complications are there, lots of viral infection, many things, dengue, chikungunya with pregnancy. So many new things are there, we can say, in last 1 or 2 decades. And which will lead to lots of changes in our obstetric practice. And because of all this, now we are facing more and more high-risk patients, and the need for obstetric HDU increasing day by day. So when such type of patients are admitted in obstetric HDU ICU, protocols and checklists are placed in such a way that encourage appropriate and immediate responses to the critical situations. Initial assessment is done, fetal and maternal and fetal conditions are assessed, immediately resuscitations if required done, baseline and specific investigations are carried out as indicated, and then monitoring of a patient started. When patient in obstetric HDU ICU, different type of monitoring is possible, maybe in the form of non-invasive hemodynamic monitoring, cardiovascular monitoring, respiratory monitoring, renal function monitoring, neurological imaging monitoring. All is possible when they are admitted in obstetric HDU ICU. And these are the recent data of Fox's registry for COVID-19, and it is observed that before pandemic of COVID-19, the need for obstetric ICU admission across India and across the world is usually between 1 to 1.5%. But during pregnancy, during this pandemic, when our pregnant women infected with COVID-19, in this such type of patients, 7.19% of the pregnant women infected with COVID-19 require critical care admission in ICU admission. That means with COVID-19 infection, pregnant women require intensive care facility admission 5 to 7 times more. So when patients, pregnant woman with COVID-19 who has age more than 45, BMI more than 35, or having pre-existing any comorbidity, when their respiratory rate is more than 30, or when their oxygen saturation is less than 93, or when there is oxygen saturation less than 93, even at rest or after a walk of 6 minutes, when there is a rapidly progressing abnormality or lung imaging or pneumonia, when peak SOFA score is positive, when IL-6 is increased significantly, or when pregnant woman with COVID-19 infection having high CRP, high serum ferritin, LDH significantly increased, and when NLR ratio is more than 3.1, all such patients may require intensive care, may become critically severely ill, and are very, very vulnerable for mortality. When patients are there in HDU ICU, non-invasive monitoring, inotropic supports, nutritional support, pain management, fluid balance, electrolyte corrections, oxygen therapy, surgical wound care can be taken, blood transmission is possible, hypertensive and anticoagulants are also therapy can be given if required. Invasive monitoring is possible. So all this different type of management and monitoring is carried out as per the requirement of the patient and is possible when patient is admitted in obstetric HDU and ICU, which was not possible before a decade in India, because they all need to admission only in routine floor or in MICU. And MICU, there were no space for MICU. All MICUs were full, no beds were available. So our patients have to admitted on routine floor where we were not able to provide all such type of facilities or services or management and monitoring. Now with the advent of obstetric HDU ICU, our obstetric patients are admitted under us in obstetric HDU ICU, and we can provide all such type of monitoring and management, and we can save them. So there is a great impact. Following the advent of HDU, the need for mechanical ventilation became the major indication for maternal ICU. Previously, hemodynamically unstable patients at number 1 for the admission in ICU. Now it has changed. Most of the hemodynamic unstable patients are taken care, are managed and improved with HDU facility, and now the mechanical ventilation become number 1 indication for the admission in maternal ICU, obstetric ICU. So the burden of ICU reduced to 1/3, and the total treatment cost also reduced to 35-40% at an average of 38%. As per the study conducted in 2016 by Foxy, out of in 4 institutes the study was conducted, and out of 52,641 deliveries, the utilization rate of obstetric HDU was 4.85%. I was the resource person for this study, and the complications of HDP was the number 1 indication for admission. With second was the hemorrhage, and then the sepsis. And these are the important data where in this Surat Medical College, 1 year prior to the advent of the obstetric HDU and 1 year after the advent, comparison of maternal mortality is there. Maternal mortality, which was 2.2% because of APH, has improved to 0%. Mortality because of PPH, which was 5.9% in 2014-15, improved to 2% after establishment of obstetric HDU. Mortality because of hypertensive disorder, which was 2.9, has improved to 0.8. Mortality because of anemia, severe anemia, 1.1, has improved to 0.4. Mortality because of jaundice, which was 16.1%, improved to 4.9%. With heart disease, which was 7%, improved to 1.3%. So in all the such type of conditions and complications, maternal mortality has improved by 60% in a single year within the facility of intensive care, close monitoring in HDU ICU. Similarly, these are the data of Wardha Medical College, Maharashtra, comparison of 1 year prior to the advent of obstetric HDU and after 1 year after establishment of obstetric HDU. Again, we can see in all such conditions, APH, PPH, HDP, anemia, jaundice, heart disease, sickle cell crisis, total mortality, which was 5.9%, has improved to 1.9%. So again, we can see that 50 to 60% of the improvement of maternal mortality occurs within a single year in many of the medical colleges or the public hospitals. Now, 300 of the medical colleges are having this establishment, and Government of India, when going outside India and presenting their reports or in health summits, the Government of India health authorities are presenting the data of maternal mortality improvement because of the obstetric HDU ICU establishment in India, with proud that we can reduce significant maternal mortality with this advent establishment. So the maternal mortality in India, which was these are the recent data. In Kerala now 43, Maharashtra 48, Tamil Nadu 60, Telangana 63, Andhra Pradesh 65, Gujarat 70, Jharkhand 71. Again, now there is a significant pace in improvement in the maternal mortality across India with this establishment of obstetric HDU ICU because it has a significant scope and role. And now in India, nearly 11 states we are having their maternal mortality below 100. And again, we are expecting that we would be able to achieve SDG goal quite before 2030. And most of the state will have maternal mortality less than 70 within next 4 or 5 years. So in conclusion, a dedicated obstetric ICU with the experience and expertise of obstetrician specialized team would be the best place to monitor and treat the critically ill obstetric patients. Obstetric HDU ICU are complementary to each other. It allows continuity of antenatal, intrapartum, and postnatal care at the same place by the same team. Every year, as per WHO 2015, 3 lakh pregnant women die in the world, and it is said that if quality obstetric healthcare is provided in time, then we could save 80% of these pregnant women. I mean, 240,000 women are dying just because of lack of this facility. And with the establishment of this obstetric HDU ICU and critical care, quality obstetric healthcare, I hope we would be able to save those women, significant number of women, pregnant women. So the obstetric HDU ICU means quality care, means a concept, a setup, an establishment, a facility. Quality obstetric care is a vital backup and need of the hour. Safe maternity is a basic human right. It is not a commodity for the privileged only. Once American past President Barack Obama declared that we did not come to fear the future, we came here to save it. And similarly, being a professional organization, being a personally, we all are the professional persons, and being the main stakeholder of women's healthcare in India, we also try to fear the future. We also try to save the future of pregnant women, and we should not fear. And we also jointly work to achieve the SDG goal for India 67 by 2030. A big section of our society in India is still unreached, underprivileged, deprived of benefits of life-saving infrastructure, technology, and facilities. And it is our moral responsibility to reach to them, to provide this facility to them, and to save our mothers and future generation. Thank you very much for the opportunity, and thank you very much for the patient hearing. Thank you.
Thank you, sir.
Thank you, Dr. Alpesh, for the very excellent talk on ICU and HDU. We know that obstetrics is a very unpredictable branch, so we should be prepared. And you have laid down the guidelines where we should admit the patient in HDU, where in ICU, and what are the requirements of both for both the session. Thank you so much. We'll keep this in mind in future. And help.
Shukla here.
I'm so sorry.
Thank you, Dr. Pratibha, for giving us the opportunity to chair the session, and it was a very, very informative session. Yes, we should know which patient to send to HDU and ICU. But till the patient, sometimes many of still are being delivered in the periphery, right? And till the time they reach us, so sometimes they're in such a bad condition that it's unable to tackle them also. So we should train the periphery staff also how to maintain that patient, so that till the time they need to refer that patient to a particular ICU or HDU, the basic vitals are maintained and they have been given a good fluid intake and everything. This way we can also reduce the maternal mortality. Yes, the staff which is trained for the ICU and HDU should be regularly monitored, so that at the time of emergency, they are all ready to do to support the doctor in need. And yes, then there should be, I think so, counseling of the patient, which is very important, as because at ICU and HDU, the patients are already at high risk. So counseling plays a very, very important part of the. Thank you, Dr.
So 3 delay are always a very important, and 3 delays can cause many mortality, morbidity. We all know that, and it is. We also, I think nowadays it should not be there. In few decades before, it was okay because transportation facility there were problem with many problems were there. But now with lot of update of knowledge, lot of availability of technology, and with the facility of transportation, I think, and with better referral system, this should not be there. But yes, it is still happening at some part. So we should take care of this late referral. And of course, they all our members, all support staff, and particularly those who are working at triage area should be trained. So immediately, I think these parameters are very simple to take, and within a minute, we can decide where to admit such patient from triage area. So even at last minute, when they reach to this triage area, if they are trained, they can easily take decision where to admit such patient. Just from this vital data also, they can decide where to admit this patient. Unnecessarily, they should not be admitted first to the floor, and then the doctor or gynecologist working in the floor, then again shift the patient to the HDU, and it will take a lot of time in transportation of the patient from one place to another, and an unnecessary situation can be worsened. So this is very, very important. Triaging is very important.
Thank you so much. Eye-opening talk, not only on the whole of quality obstetric care, but also on HDU, ICU, the need for such units in bringing in us achieving our SDG goals, how to set up these units, equipments, and you updated us with all the new concepts in the critical care obstetrics. And we are also appreciative of your selfless and relentless work in this direction, sir. So thank you. Thanks a lot, sir. And now after Sir
I would like to pay my regards to Madam Shanti Roy. Madam, namaste.
Namaste. Thank you very much. The lecture was very, very nice. I enjoyed it, and I heard it from A to Z. It is a practical thing what you have done. You have really walked over it, and then you have presented it. I think government should issue a notification that all districts should have one SDU where the criteria should be fixed that with this criteria the patient will be admitted.
Madam, government took decision that by 2021, end of 2021, there will be 500 obstetric HDU ICU functioning in India. That decision was taken 2-3 years before. Okay. The only problem in between, we were not knowing about the COVID. Now, because of COVID, at present, we have more than 300 HDU ICU functioning. But I think within a year or two, it will reach to 500 because now, new NMC has made it mandatory that and it is mandatory since last 3-4 years that for beginning of any medical college, for running of any medical college, obstetric HDU ICU is must compulsory. So we have more than nearly 450 medical colleges across India, and government in the second phase, government has decided to go to the district hospitals. So once medical college hospitals will be taken care, then in next step, there will be a district hospital. Even at present, in some of the states, state government took decision already, and obstetric HDU are now established in few of the district hospitals also. So I think next 4-5 years are very important, and we will have facilities to all these districts also.
This is a great thing.
Madam, we all will miss you. Madam, we all will miss you at Ahmedabad, and I would like to request all the delegates and all the speakers, please to join at Ahmedabad International Conference for Critical Care in Obstetrics on 17, 18, and 19. It is 7th in number since 2013. Every year we have one critical care in obstetric conference. It is always in demand, and always we have to stop the registration in this conference. So because of COVID, we are permitted for a limited number of delegates. So I request all those interested members, if you are interested, this is the physical conference after such a long time at Ahmedabad, and you all will enjoy. A very good scientific program is there on our website. 12 international faculties are there, all are renowned faculties. So definitely you will enjoy the scientific feast as well as hospitality of Ahmedabad Society. Dr. Munjal Pandya, Secretary of Ahmedabad Society, is already there. And I request all of you, please join for this conference.
Yes, sir. We are looking forward for this conference. Yes, sir.
Thank you. Thank you.
Thank you so much, sir. And I'm sure everyone would love to attend the conference, sir. And now moving on with the deliberations for today, after sir's scintillating talk, we have a most aptly poised surprise question for the day for our audience, and an excellent prize also for this. So the winner for today's surprise quiz will win a certificate and a book on practical approach to critical care and obstetrics, edited by Alpesh Gandhi sir, Dr. Jyotsna Suri, Dr. Pratima Mittal, and Mala Arora ma'am. And the surprise quiz for this episode of Critical Care and Obstetrics is, can I have the question? Yes. So a high dependency unit has to have all of the following facilities except an airway access equipment, suction apparatus, vascular access equipment, or invasive ventilator support. And for all of us who have keenly listened to sir's talk, I think it's a really easy question, ma'am.
Except the last one.
So don't reveal the answer. Yeah, so the poll has ended and we'll be declaring the results in the next episodes of the web series. Yeah, and now moving on to the third session of the day. Can I have the slides, please? We move on to the debate round, a much awaited debate. And I think it's been a most, exciting day today. And our debate is also on a very practical topic, a topic which really interests all of us. That what is the role of advanced cardiac assessment for all antenatal patients? And I invite my chairpersons for the debate today. Can I have the series, please? Our chairperson, first chairperson is Dr. Lakshmi Shikhande, ma'am. Welcome, ma'am. Ma'am is the chairperson-elect, the Indian College of Obs and Gynae, the National Corresponding Editor, Journal of Obs and Gynae, or JOGI, National Corresponding Secretary, Association of Medical Women India, founder, patron, and president, ISUPA Vidarbha Chapter, chairperson, IMS Education Committee, president, Association of Medical Women, Nagpur. She has several awards to her credit: Nagpur Ratan Excellence Award, Hansotia Best Committee Award, and appreciation letter from Maharashtra government, and she has held various prestigious posts in the past. So I welcome you, ma'am, to judge this debate today, and we are very glad to have you here with us. Our next chairperson is Dr. Sujata Dalvi, ma'am. She's a senior consultant obstetrician and gynecologist in Mumbai, practicing in various hospitals. She's an honorary clinical hospital. She's a joint of Jogi, Joint Clinical Secretary, Mumbai Obs and Gynae Society, and the first Joint Secretary of AMOGS. So welcome, Sujata, ma'am. And I invite Lakshmi, ma'am, to introduce our debaters for today. And can you have the series, please?
Yeah, very good evening to one and all. I am also eager to listen to both the debaters, Archana and Munjal, whether advanced cardiac assessment is needed for all antenatal patients, yes or no. So let us see how these two debaters are going to debate. And I would like to introduce the first debater who is speaking for yes, that is Dr. Archana Singh. She has done fellowship in reproductive medicine and daycare endoscopy. Currently, she is Professor OBGY at Osmania Medical College, Hyderabad, and she is consultant at Yashoda Hospital, Hyderabad. So Archana, we are all eager to hear you for your yes on advanced cardiac assessment. Yes.
A very good evening to all of you. I feel blessed and honored to be with Dr. Shanti Roy, and it has been wonderful to be with everyone on the same dais. In spite of the distance, I feel we are all together. So what has brought us all together? Correctly said that we all aim that SDG goal should be achieved earlier the better. So we want our maternal mortality rate to reduce. So we all know about the golden rule, that golden hour is the most important. And if we find something beforehand, maybe we can stop something, we can prevent some complication and save a mother. So all of us know what to do and what all things to diagnose. I will share only my few experiences which gave a lesson to me. A 26-year-old woman, she was a gravida 3 with previous to abortion, married for 8 years, and she had 37 weeks of gestation. She was referred from a primary health center, and the presenting complaint was draining since 3 hours, and then we did ultrasound. So earlier, the ultrasound earlier was having 32 weeks breech presentation. When we repeated our scan in our hospital, again it was term, but breech presentation, and hence we took her immediately for cesarean section. We did routine investigation and ECG. ECG was the postgraduate, the first year anesthetist mostly will see, and he said yeah, everything is normal, and we took the section, and unfortunately we lost the patient after a few hours with sudden cardiac arrest. And then again we went to take the detailed history. The parents were there. They said that her patient had difficulty in breathing, easy fatigability, but they thought that because she is in mother-in-law's place and all those things, and she had worked and then she was taken care and everything is fine now. Then again we took detail, and they said that there was some issues of health issues in earlier childhood also, which was concealed. Coming to second case, she was a 24-year-old woman, gravida 2 with previous cesarean section. She was referred as a case of bleeding per vaginum, and previous scan which was done was showing low-lying placenta. As she was already bleeding, we took her for cesarean section immediately, and ECG was equivocal. But in this case, what happened when we opened it, we found that there was placenta accreta rather than low-lying placenta, and which was adherent. Then we started going for hysterectomy. Then we changed it to general anesthesia, and luckily that time also the patient was fine. But unfortunately, there was an injury in the when there was internal iliac ligation. Then again we had to call him the surgeon, and then we saved that part. But unfortunately, we lost the patient, and then we were told that the patient had cardiac problem, and the patient attendant had not shown earlier, but because under the anesthesia everything was monitored, she was fine, and later we lost the patient not because of the surgical issues but because of the cardiac problem. So what happens in the pregnancy is the cardiovascular system is progressively stressed during pregnancy. The first stage of labor, the cardiac output increases 10% above normal. The second stage, 50% above normal, and immediately after delivery, it is 80% above normal. And each uterine contraction, 20% increase in cardiac output is there. We all know that there will be certain patients who are asymptomatic. They might not be even knowing that they are having any cardiac issues. And then these patients may be lost in case any surgical complication happens, because the duration of surgery or the normal labor may not be so easy for them. Before pregnancy, the blood volume is 4.2, the diastolic BP is 67 or 108, the cardiac output is 4.9 liter, and there is 11% increase in labor. The hemodynamic changes during labor will be depending upon the position, the phase of the labor, the pain and anxiety, and the oxygen consumption increases by 23% during labor. We all know about the New York Heart Classification about no limitation of physical activity, slight limitation of physical activity, and moderate limitation of physical activity in class 3 and 4 is unable to carry out any physical activity. And the stages of cardiac failure can be presence of advanced heart disease in stage D with continued heart failure symptom requiring aggressive medical therapy, but many of them will be in the presence of, with no heart disease or no symptom in the presence of heart failure. So these category becomes the high risk zone. We are having the stratification risk score of poor functional class with previous cardiovascular events, the left heart obstruction, and the left ventricular systolic dysfunction. But we know that many times it becomes a social stigma, or the patient may be going from one place to other. There will be migration of the population. All these things, they may not have the paper, they may not realize the gravity of the situation. And once they are coming to us, assuming that everything is fine, and then if we get into complication, it is not only the medical complication, the overall, the shock which the patient gets, we also share that. The predicted risk for maternal cardiac events in pregnancy with a point score of 0 to 1 point was 5% and 2 point was 10%. So 4 lesion specific predictor, say mechanical wall is there, aortopathy is there, then definitely we know. But cardiac events also are important to know in most of the cases. So maternal mortality can range from 5 to 50% depending upon which cardiac disease she is having, what is the systemic ventricular dysfunction, or there is a New York class, depending on the New York classification. So it may be reduced definitely if we know everything beforehand. The timing of delivery also is important. In case the patient is having a very she may not be able to continue pregnancy, then it is important that we know that the patient needs intervention and termination, or if the patient is having any complication, we should have tested so that we can plan her delivery at the optimum time. Coming to the prerequisite, if we know beforehand the complication and the importance of cardiac disease which she is undergoing, then it becomes easy that what all things we are having in the hospital, because still there is a certain population which will be in the far off place with poor transport, and in these cases it is important that they are getting admitted at 30 weeks or 28 weeks depending upon their complication rather than we are waiting for it. Induction of labor itself, once or twice it has happened that the patient was diagnosed at cardiac disease, although already she was induced, and then we realized that she needs a cesarean section, and then ECG was done, and then echo was done. So preferred position of vaginal delivery will change when the patient is having cardiac disease, and not dorsal but semi-recumbent position will be needed. The setup of delivery tray, the unit for conducting vaginal delivery will all be changed depending upon the gravity of the situation. Then comes the pain relief. The most important part is the pain relief which is needed in a cardiac patient. The Lasix, the cutting short of the second stage, the judicious use of IV fluids. All these things becomes important when we know that the patient is having cardiac disease and what category of cardiac disease she is having. Then comes to IV fluid, how much we have to give, how slow we should give, and monitoring of mother and baby. It becomes important if we know that the baby, if there is any congenital heart disease for the baby, and immediate intervention is needed. And most important, when at present we are not hesitating in doing 2D echo for fetal echo for baby to rule out any cardiac problem. So why there is doubt also that we should not go for advanced cardiac assessment of the patient, because even a single patient will make us think that why we have lost her. The optimum analgesia and anesthesia also will be decided upon the cardiac condition of the patient, how much pain she can suffer, and the communication, the counseling, the birth attendant, and giving of epidural analgesia will be important, because in many times in so-called tertiary care center where I am also working, but there also it becomes impossible that individual patient attendant is there. So it is important that if we know that beforehand that she is having this sort of cardiac disease, it becomes easy for us to diagnose and take care of the patient even in the worst scenario. Then coming to the delivery, allowing the passive descent of the fetal head, the shortening of the second stage, and assisting it with either forceps for delivery when the head reaches the perineum. And if we know which type of cardiac disease it is there, is it coarctation of aorta, or a dissecting aneurysm, or a critical MS, or New York classification 3 or 4, in these cases, we will avoid vaginal delivery. And coming to cesarean section, if the aortopathy is there, the aortic dissection is there, severe AS or recent MI is there, these cases definitely we are going for planning beforehand. And obstetric indication, if the patient is having, we should know that this patient is having a cardiac disease and intervention may be needed, and we are having all the facilities to take care of the patient. General anesthesia versus regional anesthesia becomes important in a case of cardiac disease and the type of cardiac disease. The uterotonics, the oxytocin, low-dose infusion, avoiding bolus, and avoiding prostaglandins becomes important. And if the patient is already having anticoagulant for other purpose, we have to stop it and for 12 hours before labor, and to start 12 hours after immediate post-op. And this will be known only if we have done proper diagnosis of the patient. We can also classify them in the high risk and the moderate risk depending upon the investigations.
Right. Ma'am, can you sum up now? 1 minute.
Yeah. This is the last one. So it is a team effort. And we all know that if there is a murmur in the heart, we have to be ready for the complication. We don't want thrill in obstetric care. We want the best outcome for the patient. So it is important that high-risk care obstetrician should be taking care of the patient in presence of cardiologist with all the advanced technological advancement so that we get the best result for mother and baby. Thank you.
Thank you, Dr. Archana. Can we have the next speaker slide, please? And I request Dr. Sujata ma'am to introduce our next debater.
Yeah. Thank you so much. First of all, I would like to thank the Dr. Pratima Singh of today's program, Dr. Priyankur Roy, Dr. Diksha, and Dr. Vartika for giving me an opportunity to be a part of this program. And also, of course, my co-judge, Dr. Lakshmi Srikhande, to be a part of this debate. So can I have Dr. Munjal's introduction slide? So after scientific deliberation from Dr. Archana Singh for going all the way and going all way for cardiac evaluations for all antenatal patients, we have Dr. Munjal, who is going to speak on whether do we really need to go all the way and evaluate a patient, antenatal patients from cardiac point of view. So Dr. Munjal is an assistant professor at AMC Medical College, Ahmedabad. He is an honorary secretary of Ahmedabad OBGYN Society. He's received Dr. Shirish Daftari's Young Talent Award for AOGAs for the year 2017 and 18. He's co-edited a book on male infertility and is winner of Dr. Kamini Rao's Zone Yuva Foxy Oration for the year 2021. And he has published many papers and chapters, and he has got various hobbies. So let us listen into Dr. Munjal Pandya, who will be talking whether do we really need to evaluate the antenatal patients from cardiac point of view. Over to Dr. Munjal.
Thank you so much, madam. Thank you, Dr. Pratibha Singh, madam, all the team, all the respected seniors and faculties for inviting me and making a part of this academic session. Just a second. So I hope the presentation is visible.
Yes.
Yes.
Yes, ma'am. Thank you. Thank you. Basically, it is advanced cardiac assessment mandatory for all antenatal women. I'm going to speak against that particular notion. I would agree to one particular thing with regards to Dr. Archana, madam, that is each and every pregnancy is precious and each and every life we save is precious. Rest of the things I need to actually object upon for the role I'm playing right now. We know the physiological changes. Madam has very well highlighted the changes. Right from 32 weeks, the patient becomes vulnerable with regards to increase in cardiac output as well as the arterial pressure. That is basically the diastolic one as well. These are the changes Madam has already highlighted. During each uterine contraction, the rise in heart rate would be around 40 to 50%. With each stage of labor, it would be the cardiac output would be rising over and above the status that already is 50% beyond the pre-pregnant state. So the rise will be again, double. So it will be like almost 3 to 4 times than the pre-pregnant status. So the changes in cardiovascular system would be a great challenge with regards to the maternal body. Now, coming on to the incidence of cardiac disease, the prevalence of cardiac disease was noted to be at least, 3 to, just a second, at least 3 to 4% at the max, not more than that from various studies or the literature. But the conditions which would actually, aggravate the cardiovascular derangements would be hypertension, diabetes mellitus, and congenital heart disease. Now, we need to focus upon these conditions because these are more accessible than finding out the cardiac disease or, notion, which is actually rare in comparison to these conditions. Evaluation of cardiac disease in pregnant females will often require advanced workup. So it is the cardiac disease whose presence needs to be there for the need of advanced workup or cardiac assessment. The initial basic workup in form of CBC, urine analysis would be enough for the patients who are not having any history or the symptoms. Hemoglobin and hematocrit would be there for each trimester if the patient has cardiovascular disease, because a little anemia would actually cause much of derangement in cardiovascular system of those patients who are having cardiovascular disease, not the normal non-cardiac patients. Routine creatinine, liver function, renal function test we would be doing anyway. Brain natriuretic peptide is something which is very much specific for the females who are having cardiac disease or history of cardiomyopathy or suspicion of having cardiomyopathy. With regards to ECG, one more investigation which is not routinely done. It is basically not routinely done because in normal pregnancy, the heart usually deviates towards left, which would reflect upon as left axis deviation in ECG, which is again normal. So it is normal even in pregnancy. With cardiac disease, there might be other changes because of dilatation of chambers of heart, which may precipitate various kind of arrhythmias. But again, we need to remember that non-specific changes to STT segments would be normal in 14% of pregnancies who are not having cardiac problems. So again, the false positive rates are still there. If you subject the patient to ECG and they are coming out with some changes, it does not necessitate further evaluation in form of cardiac disease evaluation. The echocardiography, again, we know that physiological changes would lead to normal chamber enlargement, physiological regurgitations, valvular regurgitations, and valvular dilatation. And there is no strict cutoff between normal and abnormal finding. Again, we need to be cautious while interpreting the echocardiography. And pericardial effusion may also be there in pregnancy. In small amount can be physiological. So again, we cannot stamp that particular patient having some cardiac problem or cardiac disease. With regards to cardiovascular disease in pregnancy, in California, they developed a toolkit in November 2017, which had key components in form of an algorithm to guide stratification and initial evaluation of symptomatic high-risk pregnancy and postpartum females. Again, this word is very important, symptomatic. The goal is to assist providers in distinguishing between signs and symptoms of cardiac disease and those of normal pregnancy. And remember, we are talking about a developed country, USA, who is having the highest GDP all over the globe. And still they are choosing out their patients for further or advanced cardiac assessment. They are not fooled, I guess. With regards to that particular algorithm and protocol, we do have this 4 columns. With regards to symptoms, there has to be one of the symptoms present. With regards to vital signs, there has to be one or more of vital signs getting abnormal. With regards to risk factors, there has to be one or more risk factors present. And with regards to physical examination, there has to be presence of some pathological finding to go ahead with even further evaluation or cardiac evaluation. We cannot subject each and every antenatal patient to advanced cardiac workup. Again, this is a summary of that particular checklist with presence of one or more risk factors or symptoms or signs for further evaluation of cardiac status. One more literature suggested in 2018 that pregnant patients at intermediate and high risk would require special care. Even healthy pregnant patients often complain of edema or breathlessness during this period. So further evaluation is only for females with heart disease. And as Madam said, antenatal and perinatal management by multidisciplinary team experienced in cardiovascular disease is recommended for females with underlying congenital heart disease and other severe cardiovascular conditions. Now, this is one more ACOG bulletin publication in 2018. They had 3 columns in form of routine care or reassurance is required for no history of CVD, for self-reported symptoms, for shortness of breath, not only on heavy exertion, which is considered to be normal. Fatigue in mild degree is considered to be normal. Heart rate less than 90. Physical examination normal and edema mild. These are normal findings and needs only reassurance. Modified WHO risk assessment model is most widely accepted and validated in pregnant females with no known cardiovascular disease. So each and every guidelines constantly focuses upon those patients who are symptomatic or fall into this particular high-risk category. The rest of the patients do not require further or advanced cardiac workup. One more guidelines by European Journal of Heart Failure in May 2016 highlighted that modified WHO risk classification is a useful tool for predicting cardiac events during pregnancy in females with established cardiac disease in advanced countries. Remember that we are talking about advanced and developed countries. Even with developing country like India, we would see all the problems that we might face with regards to the that particular guideline of having all patients undergoing advanced cardiac workup. So this is particular graph of population explosion. The rate graph is of India. If we can see, it is exponentially rising. We will overtake the China within few years, and think of the catastrophe we would have with regards to the burden on health sector. And we are talking about advanced monitoring. This is a proportion. It may surprise many, but we are still having 70% of population in rural population, and only 30% in 2011 census. We are having to be urban population. We cannot run away from this fact. Think of the cost on the health sector we might have by propagating such thought. Think of the centers. Do we have enough centers in form of even primary health centers or even first referral units? You just talk to PSM people, they would speak it loud that we are having a lesser doctor population ratio. What about the equipments? They are costly equipments. Even echocardiography cannot be afforded by many. Then what about the physicians? Do we have physicians? We are talking about normal MBBS doctor population ratio, and then cardiologists. So even a physician would require help of cardiologists, which are not even enough in urban population. Health indicators, think of birth registration. The data shows that it is not beyond 60%, even in urban population. Look at the second bar, skilled birth attendant. Even urban population has not achieved 100% skilled birth attendant delivery. Think of rural population having only 43%. Think of anemia. With pregnant females, we are having still 50 to 60% females, both in urban and rural population, to be having anemic. So these are basic needs. These are basic things we can focus upon and which needs to be treated first before jumping onto something that is advanced. Think of infant mortality rate. We are still struggling with regards to SDG now. Access to basic services. See the first bar. Even 45% of rural area does not have electricity. What about echocardiography machines? Where do we run those machines? What about sonography, fetal normal basic sonography? Think of the households with toilet. There are various parameters which we are struggling on. We cannot have a building built without infrastructure or the proper base. We are lacking that particular base because of population explosion and lack of basic facilities. So stop doing unnecessary things. Ask yourself question, is that really necessary? As often as you can, and most of the times you will end up as no, it is not necessary. Think of explanation to the couple. When you explain some of the advanced monitoring tests, what would happen in their minds? They will be agitated with the possibility of getting those tests negative, even they are not having symptoms. And the sleepless nights till the results come. And then with the results, in their mobile, most of the times, yes, they would actually keep on praying 1,000 times before opening up that particular report or message. Think of the fear and anxiety we are creating. As it is said, that fears and insecurities are unconsciously created by you, that is us. If you do not create them, they do not exist. And they would actually change the gynecologist. So think about losing those patients and all the relatives or other patients they might have brought to you. We need this. We need calm and composed couple to have a healthy and happy baby with proper monitoring. And the ultimate outcome, with irrespective of their socioeconomic strata, has to be happy faces and healthy faces. As Oscar Wilde said, we live in an age when unnecessary things are only necessities. We know her. She said, the world is full of a lot of negativity and fear and a lot of judgment. I just think people need to start shifting into joy and happiness. As corny as it sounds, we need to make it this particular shift. And as he says, Jeff Bezos, though we are optimistic, we must remain vigilant and maintain a sense of urgency. So I would say we cannot subject the patients towards something that is not necessary for them. And that is how we can actually serve the purpose of having optimal outcome of pregnancy in form of better maternal as well as neonatal outcome. Thank you. Thank you so much.
Okay. Thank you, Dr. Munjal. He has put forward his points. We should, I think, give a chance to Dr. Archana Singh to just maybe put her points, after listening to Dr. Munjal, because she put something on the chat. So I thought maybe we could give her a chance to speak.
Yeah. 2 minutes for Dr. Archana. Yes.
I just wanted to say that if we lose one patient, then your clinical practice goes down like anything. So losing few patients, and if they are going to other doctor, I won't mind that my patients are going to Dr. Munjal, but I don't like losing a life of a patient, because that trauma, it is not the trauma that the patient has died. Maybe patient may not create any legal issues for you, but the trauma, it is, both the experiences were 10 years or 5 years back, but you'll always remember that maybe I could have saved the patient. And when it comes to ourselves, do we go for the best test? If it is my child, if it is my mother, I go for the best result, best hospital. So let us try. Yes, India is a poor country. India has all the problems. But if given a chance, how many patients don't want ultrasound for the baby? Everybody wants to go for TIFA. Most of us want to go for Down syndrome testing. Not all babies born will be Down syndrome, but we go for it. So let us, in case it is available, definitely we should try. If it is not available, definitely we should aspire for it. Try for the best. If it is not there, at least our goal should be for the best.
Can I ask one question, madam? Honest question.
Yeah.
To how many patients would you do you prescribe 4D sonography, madam? Out of 100. Out of 100, yes.
Yeah. I work in both government and corporate. Government only, because 20 is only allowed for us. More than 20 at any point of week, we are not allowed.
No, in private, madam. How many? In private.
In private, I discuss with all. If they are willing, they go for it. If they are not willing, I don't insist. But I give them the option. Sure. I give the option for everybody.
Okay. The only thing I wanted to highlight was starting from first trimester, madam, we have this NIPT, which is not 100%. Then we need to opt up to amniocentesis, which is again costing 15,000. Then we would be having double marker. Then we will have triple marker. Then we will have quadruple marker. Then we will have anomaly scan. Then we will have this hydrocephalus scan at 26. Then we will have, RH isoimmunization screening. We have everything to stress upon those particular couple. We have a simple stethoscope to diagnose that diastolic murmur. That does everything, madam. Honestly, that does everything. And with regards to hiding that particular history, it's the trust that they put in us, it's the counseling that we do. And then again, it's like a lot of things can be done before putting them onto that instrumentation. That's what I can say, madam. Thank you.
Munjal and Archana, now your time is over.
Thank you.
Now, as a judge, we have to pitch in, and I agree, Archana, each and every life is precious. But what Munjal is saying is absolutely correct, that we are going away from the basic skills and we are relying more on the technology. Detailed history taking, manual pulse counting. Is your resident or sister really counting the pulse for 1 minute? Simple stethoscope, what he is saying, which was taught to us during postgraduate days, that each and every antenatal patient, we have to auscultate. So how many of residents or how many of us are really auscultating? Because advanced test is not a panacea. What Dr. Munjal has said, that you should know that this lady is having a congenital disease, heart problem, then only there is a sense in doing the advanced test. Because once you are ordering any test, be it ECG, echo, whatever, you should know how to interpret it. And second most important question is whether by ordering this test or whether by the result of this test, the management is going to change. Just because patient is affording, you have got all the facilities available, all the tests available, is not an indication to do the test. Because if you get results, false results, you are in a panic mode, your patient is a panic mode, and it is not worth doing. In your first case, the ECG was read by the first year resident. I mean, it is ideally the anesthetist who has to just have a glance at the ECG before giving anesthesia, if ECG is at all available. Because we even don't do routinely ECG for all patients. In your history taking, throughout your 9-month monitoring, you can really pick up the cases who need ECG, echo, or advanced testing. If it is not picked up, I think somewhere our care is lacking. Because once you diagnose the case, problem is there, yes, go for advanced test. I fully agree with you, Archana, because once the disease is there, it will definitely change your entire management, antenatal, intranatal, postnatal, whatever you have described in detail. But I will go with Munjal that not all antenatal patients, you have to go for advanced antenatal test. And why so? Munjal has already said, and I have also briefed. So I am in favor of Munjal that we don't have to do advanced cardiac assessment for all our antenatal patients. Yes, Sujata, your view.
Yeah, thank you, Dr. Lakshmi. I would also go with Dr. Lakshmi that main thing is an auscultation of the patient. All residents should be taught, especially for the first antenatal visit. They need not keep it repeatedly auscultate all patients, but the first antenatal visit, auscultation has to be there just to find out presence of any murmur. They need not diagnose it's a diastolic or a systolic murmur, but something which is more than just hearing the heart sounds, and they can always ask for some cardio opinion or whatever it is. So I would go in for that. Of course, little hand on to the finding out the pulse, whether they get some irregular heartbeat. Yes. But I'm sure most of the residents have hardly palpated and they have hardly auscultated, to be very frank. They just go only onto the investigations rather than clinical thing. And second thing is that for all the patients, we do undergo, all patients above the age of 35 or those who are high risk or those who have undergone an IVF treatment, these are the patients we ask for ECG and 2D echo. Otherwise, for routinely, if you find that there is nothing in the history or on the clinical examination, then we don't go in for a routine or advanced cardiac evaluation. So I would also go in for the same as what Dr. Lakshmi Shikande said, that there is no need to do advanced cardiac evaluation for all routine patients. But whenever there is doubt, don't go behind. Just get it done for whatever it is worth. Whether they interpret ECG wrongly or they interpret 2D echo wrongly, it is fine. But let them just get it done. Let them be evaluated from the anesthesia. We do have an anesthesia fitness also, not only for gynec patients, but even for antenatal patients who are going to undergo elective LSCS, because now it has become a part of a routine, and sometimes the anesthetist asks for some investigations. You have time to evaluate. There's nothing wrong in that, but not as a routine part of it. But clinical examination, auscultation, taking pulse is very, and going into the details of the history, you can make out whether patient is panting, just sitting, and if she is breathless, then you can make out, okay, this patient is not looking that great. Let us just evaluate from cardiac point of view. Something of that sort, so that can be done.
And Sujata, I would like to add to your point that as a gynecologist, we are not trained to interpret the ECG or echo.
Correct.
Once you are suspecting that something is wrong with this patient from the cardiac point of view, you have to refer that her to a physician and let physician decide that whether she needs advanced test, which test, how to interpret. So it is not our domain to just order the advanced test because we don't know how to interpret them. So it is basically what you said is absolutely right. Not necessary for routine patients. Pay attention to history, auscultation, pulse, and if any doubt, refer them to a physician.
Thank you so much. Thank you, Dr. Munjal and Dr. Ashna.
Yeah, both of them were very good. They put their points very well. I must tell you, congratulate both of them.
I just wanted to thank you.
We are not discussing anything about the debaters. Both are excellent and good.
No, I just want to.
The debaters have also have to put the point forward, no?
I just want to thank Pratibha madam because she gave me the easier part. So thank you so much.
No, but Archana also
Both
put
were,
the
Archana, it was
point.
excellent. Excellent.
Thank you to Lakshmi ma'am.
Archana did try her level best, but she also know in her heart of heart that it is not necessary for all.
Yes,
It's good to argue.
Well, you are right. Her job was more tough than you.
Absolutely, madam. Absolutely. I fully agree. I fully agree to it. And that is why I kept on saying one thing, that I fully agree with that particular one life-saving part. That is important. 100% surely.
Yeah.
So thank you to our judges also for so aptly giving a summary of all the important points and their opinion. But I think still not all is lost, Archana ma'am, and we have a poll also. So let's see if we manage to sway our audience today and what the audience thinks. So the poll question for today is whether cardiac assessment is. Can I have the poll question on the screen? Yeah, is cardiac assessment mandatory for all antenatal patients? Yes or no? And all our participants who are still there can vote for this, that whether they think they are with Dr. Ashna or Dr. Munjal on this. So about 8 people have answered. We do have some votes for yes also.
Actually, you made a poll, you shifted poll from question to debater. That is why that might.
So I think so. Because those who have listened it carefully, they will know from inside that what is the right answer.
Yeah, 2 more seconds to go before we close this poll.
So we are emotional people, so we do go.
It's not bad. 53% and 47%.
Equivocal. It's an equivocal thing.
It is just like equivocal.
Dr. Archana, you managed. Yes.
Good. It's more or less equivocal. 7 and 8 out of 15.
Still, the take-home message is that routine advanced assessment is not necessary for all antenatal patients. This is the take-home message which all delegates should take with them. And they should not advise these tests to all patients.
Okay.
So thank you everyone, and I invite Pratibha Singh ma'am to wind up today's session and to thank all the faculty and the chairpersons, the judges, all our senior faculty who joined us in making this event really successful today.
So good evening once again. It was very informative today. So I'm here to give vote of thanks. And first of all, I would like to thank our viewers who could join today in spite of so many webinars at same time and made it successful. So thank you so much. And my sincere thanks to Padam Shri Dr. Shanti Roy ma'am for accepting the invitation and sparing her valuable time. So thank you so much, madam. I'm also grateful to Dr. Yashodhara Pradeep ma'am and Dr. Komal Chavan for their gracious presence. And from the bottom of my heart, I would like to thank Dr. Alpesh Gandhi sir for his excellent deliberation. And this is needed in present scenario. And I'm dead sure that it will give a great impact in our obstetric practice, especially dealing with the critically ill obstetric patients. So thank you so much, sir, for sparing your knowledge and time with us. Thank you so much. And I also want to thank our chairpersons, Dr. Vidhu Mudgal, Dr. Lalita Shukla, and our judges, Dr. Lakshmi Srikhande ma'am, and Dr. Sujata Dalvi ma'am, for their valuable inputs. So thank you so much, madam. Thank you. And hats off to our debaters for putting their best foot forward and making this debate so interesting and fruitful. So thanks, Dr. Archana Singh and Dr. Munjal. And I'm really, really thankful that you took this topic and you presented so well. Thank you so much. Finally, I'm thankful to our team, my convener, Dr. Priyankur Roy, Dr. Diksha Goswami, for all-time support. And lastly, I would like to thank our academic partners, Shield Connect, for the continuous support for last 11 months, Mr. Saurabh, Ms. Chitrakala, and Mr. Stephen. Now our next webinar is due on 9th of December, where we have yet another interesting topic. So do mark your date to join on 9th December from 6:30 p.m. onwards. Till then, goodbye and good night. So thank you so much. Thank you, madam.
Thank you. Bye. Good night.
Bye. Good night. Bye. Thank you.